Hello, everybody, and welcome to the Smart Human Podcast. Today, I have the pleasure of talking with Dr. Barry Cohen, who is one of the founders and medical directors of Mercer Kidney Institute in New Jersey, specializing in the treatment of kidney disease and hypertension for over 51 years. He was instrumental in bringing dialysis to New Jersey over 50 years ago, and he happens to be my dad. So today we talked dialysis, peritoneal dialysis, transplants, evolution of healthcare over the last 50 years, ways to protect the kidney and its function, and so much more. So stay tuned. Hello, everybody, and welcome to the Smart Human Podcast. Today, I have the pleasure of talking with Dr. Barry Cohen, who is one of the founders and medical directors of Mercer Kidney Institute in New Jersey, specializing in the treatment of kidney disease and hypertension for over 51 years. Dr. Cohen was instrumental in bringing dialysis to New Jersey over 50 years ago when he started the first chronic outpatient program in Trenton in 1977. He's done many things, which you can read in his bio, but one particular, I would say, success perhaps that he has had over the years is that he is also my dad, and I wanted to make sure that we had a great conversation to share what he knows about dialysis, hypertension, medicine. So hi, Dad. Thanks for coming on the show. I really am glad you made time because I know you're still practicing and working. So thank you for being on the show.
It's certainly my pleasure. Yeah, obviously.
Yeah, you had no choice. Okay, I got it.
No, you're my daughter, and I appreciate this. It's a fine moment.
Yeah, no, it is a fine moment, actually. And hopefully I won't, get all welled up. But anyway, let's talk turkey here. Tell my audience what is a nephrologist? That's what you've been doing for half of a century, really. What is a nephrologist?
Yeah, I think the biggest differential is sometimes to get us mixed up with the urologist. Nephrologist is obviously diseases and treatment of kidney disease of its own. And we associate that also with hypertension, which not only we treat, but cardiologists, but those that are so trained also learn how to treat hypertension for people. Despite the fact that we're nephrologists, because of the functions and different things that the kidney does, we're actually had to be trained and versed in just about every specialty there is because everything is involved around the kidney, which we might talk about. But regardless, we have to know all the specialties, all the other diseases that could occur, because they're all associated, including medications that you take with the kidney. And that's been our background. Mine from Hahnemann Medical Center in Philadelphia for 8 years, and then in the Army for 2 years. But then came to Trenton back in 1971, and A-League can carry it from there.
Well, it's interesting. I mean, just to go back a little ways, maybe some of the people listening don't even realize that we have two kidneys. Well, I mean, I know that sounds silly, but some people may not even realize that, and that they're pretty high up, almost above, where the rib cage is in the back. Some people always point to their bellies and say, my kidneys hurt. And in fact, we can, of course, live with just one kidney, which is pretty remarkable. You've been involved with transplants of kidneys as well, right? Because you don't do the surgery, but you're certainly the first, the person on the front lines that decides whose kidneys are sick enough. Tell us a little bit about that.
Well, a person can give one kidney away. Most of the time when people are really sick from the kidney, it's disease of both kidneys. So when they're in trouble and need transplantation or dialysis, which we may talk about, both kidneys are diseased. People can give one kidney away, and if they're healthy and well and still exist a normal lifestyle. There's some studies that suggest they might get trouble in the future. But
the donors. You're talking about the donors, maybe.
This is a donor that either as a cadaver, somebody who dies, you can take that kidney, but live people that donate, relatives and all, can give away one kidney if they match and still live a normal existence and then help the person that they donated the kidney to, which is often a relative or a friend situation. I think if you want to take time out just for a second to know what the kidneys do,
right?
I think that's the problem. People they know what the heart does. It pumps. They know what their brain does. It thinks. But nobody realizes the kidney does everything. The kidney gets rid of the waste that we make every day. Okay. Basically muscle waste, which is creatinine. It gets rid of any excess water that you drink. Where's it go? If you don't have it, get rid of the water, where's it go? It will build up and you'll be in heart congestion or failure. But the kidney gets rid of it and it's regulated to give up just what it has to. It gets rid of all the medications you take every single day. It has to come out. Some come to the liver, but most come out of the kidney. So knowing that, and also the kidney makes blood. The kidney has a hormone that goes and helps make blood for people to the bone marrow. It also helps blood pressure. Okay. And it helps protect the heart and the brain. If you get dehydrated or lose a lot of blood, the kidney will actually shut down to protect the heart and all. So nobody realizes, but the kidney is the most vital organs in the body for protection, for all the things we do. And then if the diseases that occur, we'll talk about, but many diseases can affect the kidney. And that's where we get in trouble with one of those items, become anemic, become heart failure, and different problems that can happen. And one of the symptoms when you get real bad kidneys, well, you don't even get that until you lose almost 90% of your kidney function. At 10% function, that's when you get sick from the kidneys, and it's usually diet, loss of appetite, weight loss, neurological, shaking, itching are the symptoms that come very late. Okay. And that's why people don't understand the significance of the kidney. They sometimes are associated with the urologists who look at just the bladder and putting out urine. And they're a surgical specialty. We're a medical specialty.
Got it. And so, I grew up with you as my dad, going to dialysis units. And understanding, I was really little, and that's when they let us in, not now with COVID, but even back then they were letting us in more freely. And I would go into the dialysis unit because most people don't even realize that the dialysis machine, which is essentially the machine that cleans people's blood or else they would die, that's really a new invention. It's only, 60 years old? Tell us about the invention of dialysis and how you got specially trained in it and then brought it to New Jersey.
Yeah, actually, there's some literature that shows it even goes back to 1800, a case here, a case there. But the real dialysis started in 1960s when people were able not to have one treatment, but to have multiple treatments on a regular basis to keep them alive. And it came from a doctor's name of Quinton and Scribner, who put a shunt, which was a tube in the artery and vein of your body, and would clamp it. They would open it up and they would attach it to a kidney machine, which would try to do to function what the kidney does. So blood would go into the kidney machine, get cleaned, and there's a mechanism we could possibly talk about, and then come back to the person cleaning. But that treatment back in 1960s would take around 6-8 hour treatments. There was even a plate dialysis at a different time with just a straight plate would take 12 hours. So unfortunately, back in the 60s, you couldn't do a lot of people. And unfortunately, a lot of people were not able to obtain dialysis at that time. It was very sad. They'd have to go to a committee and beg almost to get, can you give me dialysis? Even young people. And there wasn't enough dialysis machines around because it took 12 hours. The Scribner shunt allowed people to have open and close and be done more than one time, a couple times a week, 3 times a week. But that little shunt, unfortunately, would get infected and get clotted. And they could only put that shunt at certain places in the person's body. They moved it up the arms. And when that ran out of spaces, people couldn't be dialyzed anymore. In 66, they came up with a different mechanism by pressure where they tied an artery and vein underneath the skin without any tubing. So the infection was out and the clotting was out. And that was a big breakthrough. And then after that, a pump was developed to a machine that made the blood come out of the person's body faster. And they turned out and made the machine treatments down to 4 hours instead of 6 hours, because blood normally would come out slow. It would take, that's originally 6 hours. The pump pulled it out faster without getting people in shock, without losing too much blood out of their body, clean it and put it back to them. And it can do these treatments in 4 hours, which we now do today on a regular basis. And we do it 3 times a week, only because we want to keep people from getting well. They don't get normal, but if you didn't, as soon as they stop treatment, the waste and every other things I talked to you about get bad again. But if you do it in a couple of days, they never get sick, because you're controlling it with dialysis.
Right. They're maintaining a level where their body
we keep it. It's not a normal level, but it's a level that do not get sick. And I can tell you, just in general, fast noting that these people in dialysis are there from 5 o'clock in the morning to 12 at night. But nighttime, people that are working come get dialysis and go back to work. So dialysis doesn't put you into a nursing home. It doesn't put you at a great disability. These people who walk the streets, you wouldn't know it. They work regularly. Some of these people, obviously depends on age and the disease and everything. But dialysis can last 15, 20 years, even longer. It depends on your age and the disease that caused you to get there.
Yeah, no, it's amazing. In fact, I think I learned I guess I learned more as a younger person, but people can travel around the world. You can make dialysis appointments, go to Paris, go to Rio, go wherever you need to go. There's this whole network.
Even on ships, on vacations,
wow,
they have
cruises,
dialysis machines and nurses on the ships for vacations. And anywhere in the world except for the economics. And the economics depends on a lot of things you have to pay for it. And just as a matter of, it's very costly, but in 1983, Medicare took over the cost of dialysis, not by age, by sickness. If you're on Social Security, you could be 30, 40, 50 years, even 20 years, Medicare will pay for it. Okay. And so if you have a Social Security in 1980, and it costs billions of dollars, there's more money spent on Medicare than they spend on, unfortunately, cancer and high blood pressure for caring for people on dialysis.
No kidding.
But it's not because of money anymore. Except
that's interesting because prior to that time, so who like, I guess in the early 60s and 70s, who owned these machines? Weren't they federally owned? Our government, U.S. government
this was all
owned
private.
the machines.
Hospitals owned them, and then companies, particularly two major companies, Fresenius Medical Center and DaVita, were the big major companies. They were private. And they opened up private units outside of the hospital where people could go to. Hospitals had their own units. So when a person was chronically ill, they could be done in a hospital setting, a hospital unit, or go to these outside units and they'd be treated in those units. At that time, we started training people to go home. And they could go home to treatment on that machine. They could be trained. And then, of course, the development of peritoneal dialysis, which is an alternate treatment, different from hemodialysis. Hemodialysis means blood out of the patient, clean, back to the patient. Peritoneal dialysis was a fluid method without using blood, without needing the fistulas that we talked about. And these people could be trained to go home. And what they would do is put a tube in the abdomen of the belly. A special solution was put in that belly. And the peritoneal, the membrane there would give up the junk to that fluid, and it would come out. And people would do this every night when they're sleeping, if they wanted to, or 4 times a day if they wanted to, and go about their business. People that were working, even once they asked a nephrologist how would he want to be treated, he said peritoneal dialysis with that tube in my belly, taped to the belly. And they'd walk around that tape there, do their work, do whatever they want. At nighttime, there's a machine they could do it while they're sleeping. In the daytime, they'd be free. They had to do it every night. But this is home dialysis. Unfortunately, the government loves this. It's the best way of doing it because there's a shortage of other machines. But only about 10%, 12% of people in the country are doing it. Most people still
because you have to be well trained and have a very sterile environment.
You have to have an environment that's a clean environment because these tubes can get infected and then they infect the belly. So the environment had to be checked to be very clean and very careful when doing it with gloves and sterile situations.
So you're basically, to clarify, you're pouring a specialized solution into the abdomen, into the gut cavity.
It sits there for hours and then drained out.
Osmosis and exchange of different molecules go back and forth, and you collect all of the, kind of the waste products from your blood.
Yeah, what it's really called is, the basic treatment is a diffusion, which it means is high to low. So it means if you have a lot of junk in your body, waste, creatinine, all the waste that we have, and you run it against a membrane that lets little holes and lets certain things go through, and fluids on the other side of that membrane, but that doesn't have that waste. So what happens when they come in contact, the blood in the machine dialysis, the blood would go one way through a filter, fluid would go the other way, and in between, the junk would be given up to the fluid, it would go into the wastebasket. And you do this for 4 hours. That fluid has to be, the water that you use has to be also careful because it comes from the street water. So before it even gets to the machine, and you're into this, I know we do a lot with water.
Yeah, with water.
It goes through first a chloramine situation where it takes out the chlorine and the fluoramide that's in the water. Then it goes to a machine that takes out the hard stuff like the calcium and all, and it ends up in an RO system to get rid of the bacteria
Reverse osmosis.
and toxins. So it's three different things. Diffusion. I mean, it goes through those three. The process of giving up the waste is called diffusion. And the other process is ultrafiltration, which allows fluid that come from the blood into this wastewater so you don't get congested. If you gain 5 pounds between dialysis, between treatments, and you have no urine, and you keep getting that water, what will happen? People will go into heart failure.
Right.
The machine takes
too much fluid for the heart.
And we measure whatever they gain from one treatment, we take that out.
So you have to get weighed before and after dialysis.
And the third section called convection, that also pushes it out. But there are the three mechanisms: diffusion, ultrafiltration, and it gets rid of the waste, it gets rid of the water. And we give injections and things to make that machine work good. And the machines are set up with safety valves that measures blood pressure. And they go for 4 hours, and people can either read, they can sleep, they can watch TV. It's not painful.
Right.
And then they go about their business and don't allow them to get sick.
So the water that's used in, and has been done, I guess, since the 60s, was reverse osmosis, because even back then when reverse osmosis, which is the small poured material, that has been used for decades and decades for dialysis machines, because they were intentionally, they were looking for viruses and bacteria to catch, because those are the smallest particulate matter that gets caught in RO. What I find interesting is since that time, we've had so many thousands of chemicals that are actually bigger compounds that are getting caught anyway. So secondarily, they're now getting probably the cleanest water for the dialysis.
There's three things. It's not just the RO, which is, you're right, the bacteria, and it covers the rest of it. But before it even gets to the RO, the hard waters, because of the calcium and the things, and certain cities during the different seasons have high chloramine or chloride added, or fluoride added to the water for people's teeth and bones. It also goes through that. So we have the three different
mechanisms
before it gets to the person itself.
So
it's a tricky machine. I mean, whoever devised it is beyond me. They're really great scientists.
Yeah, I think it's fascinating. And then peritoneal is fascinating because you don't even need the machine. You're just going to sleep and you're basically pushing water into your belly, and then you're just removing the waste when you wake up.
It's a special solution. And same thing, one side of the solution has certain things in it, doesn't have waste. And the blood and the peritoneal cap, it goes around and around, gives up the waste to that fluid, and that's drained, and then new fluid's put in. So that's done through the night, maybe 5 different times, one night, and that's it. And the machine does it for you while you're sleeping. You just set up a machine. It's very safe. The trouble with that is they do get infected. Peritonitis is the main cause, where that tube in the belly can get infected. And if you get enough infections, you can treat it initially with antibiotics, but after a while, they might have to go back to hemodialysis, and they can go either way. If one fails, you can go to the other. So you go hemodialysis to peritoneal or vice versa.
I just find it fascinating that most of us don't even realize how recent in time, just 50, 60 years we've had
since the early 60s.
Yeah.
So and when I came out in 71, when I joined the hospital in 71, or my fellowship was in mid 60s, there was, like I said, 12 hours and limited situation. What is the main changes have been the time element, bringing it very down, and having this hollow fiber instead of the plate that gets it done in 4 hours, and a lot of safety mechanisms and factors that are there. And now in this country, there's over 300,000 people on dialysis.
Wow.
And unfortunately, the African Americans are on there more, maybe 4 to 1, because they get a lot more diseases in the diabetic area. And they tried to say, well, if you got on dialysis at the age of 60, how many years would you get? Initially, it was thought to be only 5 years. No, we're saying 10 years and 15 years. And they said if you're under 60, you may be on for 20 years. So it's not a short-term treatment.
Right.
I can tell you stories about a couple of people that been there forever on dialysis, and I've trained them. I know them for 30, 40 years, as well as transplant patients, because even transplant patients get at the transplant level, they give us back to the nephrologist. And I've been taking young people that I've seen at 18 to 20 years old. They're now 40 and 50 years old, still seeing in my office. They don't go back to transplant units when they're transplanted. There's still some on dialysis, and I still see them forever. And the funny part about it, I can tell you, is that seeing these people weekly for 20, 30 years, I have to say I see them more than my family.
Yeah, maybe for good reason. You never know if you're not getting along with
Well, they're very respectful. They don't ask for money, and they don't ask for allowances, and they don't ask for tuition.
I'm there now. I have a question. So, Dad, let me ask you a question. So we're going to get into some patient cases, because I know you love talking about patients, you have favorite stories, and that's really kind of cool. Tell me a little bit about who ends up on dialysis machines in the first place, because that's really a big issue. Why are we not only having patients on dialysis more and more, but now with the growing crisis with diabetes, pre-diabetes? I mean, 40% of the U.S. population has diabetes or pre-diabetes.
You're right.
Yeah.
It's unfortunate that preventive care in certain areas can stop it. The most common cause, even in the past and to the present, is diabetes.
Yeah.
But what I've seen in diabetes, when I was in the 1970s and 75, that a person who had a little bit of kidney disease, secondary to diabetes, within a year or two would be on dialysis. Nowadays, we're seeing a lot more diabetes and need preventive in that area. We can see a patient with diabetes care and carry them for 10, maybe years, even longer, and never get dialysis or get it later because of the new medications, the new changes that we've had. We have much better blood pressure care for these people and newer drugs that really help the kidneys. And the diabetic care has been unique in that attempt. Unfortunately, we still need a lot of preventive care, and diabetes still remains the main cause of people. Not only used to be go blind, they've solved that problem, but still the main cause going on dialysis. Hypertension and heart disease is the second most common causes. Lupus, which you get involved with lots of time, has been a cause with dialysis. Other metabolic things, multiple myeloma, and diseases that are only in the kidney, genetically, or disease that start in the kidney, which you try to treat with very fancy, very toxic medications, end up on the kidney machines. So they're the people that come to need that. Obstruction can be a big factor if they have obstructive disease, not know it, destroy the kidneys, and eventually see a urologist who sends us to us when the kidneys are already destroyed and might have been obstructive for many years, from stones or for congenital problems. So they're the main causes of people coming to the machines, but always early referral to the kidney doctor. And how they get referral, because primary care doctors do a basic lab studies and they do a urine. And in that basic lab studies and in that urine is the indications of the kidneys. So if you do a basic lab study and a certain substance called creatinine, which is a muscle breakdown we all have, rises up, it means the kidney's not getting rid of it, you refer it to a nephrologist. If you get a urine and see protein in that urine, you refer it to a nephrologist. Very early treatment can solve a lot of these problems. And we're still dealing with that. Education of the primary care doctors, nurse practitioners, early referral is everything.
If it's just mildly abnormal, and it's stable, does that something that a nephrologist would need, assuming need to see, assuming everyone else, everything else in terms of, so you're saying anyone who runs over the normal value at a conventional lab for creatinine.
I'll tell you, the creatinine and the urine protein, they're the two main causes of referrals to us. All the time. If we know why the cause is, whether it's a diabetic thing or a metabolic thing or treatment we have available for lupus or other diseases, lupus used to always go to dialysis if they didn't have the involvement of the skin and the bone disease. But we have now treatments that you have and we have to stop that problem and control it. The same thing with diabetics. We can help them very carefully. Diabetes, blood pressure for sure. We're specialists in blood pressure control. That was our training. Controlling blood pressure is essential, and that could be a silent killer. A lot of people don't even know they can have very high blood pressure, never know it until they get a stroke or
especially with stress now and multiple jobs and even with COVID. Symptoms. And even post-COVID, there's a lot of cardiovascular issues that are leading to some.
Well, that's another
that's a
problem
whole nother
that we've had. With dialysis, the two things that people always are worried about with hepatitis B, and we have the vaccine for it. And in fact, when I came to town in 1970, my partner had hepatitis. I was in the Army, and he called me from the Army. He trained with me, but I went in the Army, didn't open it out. He trained in if I wanted to join him, and he was sick. He was getting arthritis, and he asked me, can I come I had 2 weeks early, I've come out of the Army. I was in there for 2 years. Can I come and join him in Trenton? I'm a Philadelphia man, but I'd never been to Trenton, but come to Trenton and practice with him. But he was sick. And I told by phone that he already had hepatitis B because they didn't have the vaccine. I could tell. I came to town. I got out of the Army too. He was sick, went to the sick bed, and I started training at 4 hospitals in Trenton, not knowing my way around. He gave me one tour of the hospitals to see patients in the hospital, and he went to the sick bed. And for that time on with that, I came with a wife, a dog, and a little baby. I had no home, no money, lived in Philadelphia on the floor of my in-laws.
You weren't homeless, but you were trying to figure it all out.
We didn't have my home. So I was actually going to Philadelphia and sleeping in my in-laws' floor, coming at 7 o'clock in the morning, staying till 11 at night, because we didn't want to come back and forth.
Right.
And to treat these patients at 4 different hospitals that were in Trenton that I'd never seen before. He gave me one tour and a nighttime I'm riding around.
And he did okay, though, your partner.
Oh, no, he got over it. Yeah,
okay.
hepatitis.
The punchline was, every patient, I don't know which person this is. I'm not going to ask on the
but all dialysis patients, every single one of them get treated for hepatitis B.
Yeah. So the punchline is that was not something that was totally debilitating, even though they didn't have the vaccine. He recovered.
But that was incapacitated. He got jaundice.
Yeah.
No, it did lead some people to get liver failure and get liver transplants.
Right.
To this day, we see some of that stuff. But nowadays, any kidney patient all get treated for this initially.
Yeah.
And of course, eventually, we ought to talk about the COVID, what it's done to the kidney patients.
But acute infections, poisoning, I mean, some of the things that people don't often think about. We think of chronic illnesses like diabetes and lupus and, hypertension, longstanding. But, there are people that, and maybe you are listening, that have had maybe sepsis or some major infection.
That's usually an acute problem. It comes, you treat it, and sometimes it gets better.
Right.
The other problem is drugs.
Yeah.
Taking out drugs, and even the standard drugs. The ACE and the different drugs that you might get on a regular basis, like non-steroidals, on a chronic basis. People take certain drugs like Advil for years. It can destroy the kidney.
Right.
Dye studies can solve allergic reactions, but infections can destroy a kidney. Often, hopefully, it's an acute, meaning sudden, and suddenly may need dialysis at a short period of time, a week or two, and get better. So some of these are reversible.
Right.
But yes, there's so many other things that could be lung problems, could be heart failure problems. Some of these are reversible, though, and that's nice if you get early.
Yeah. Yeah, and I've seen lots of reversible cases that,
absolutely. It's called acute versus chronic.
Right.
Yeah.
No, I think that's awesome and really important to understand the difference, because you don't always have to stay on dialysis. Sometimes it's just a supportive measure until your kidney's shock kind of reverses itself and you can resume proper function. So now I want to know a couple of favorite patient cases. You've seen thousands of patients over the last 51 years or so. I mean, is that right? 51, half of a century you've been practicing, and you've really, everyone in this area knows you. I mean, you're pretty well known amongst all the doctors and training, even especially the nephrologists, of course. But I'm curious, have any of the patient cases or stories that you particularly love you want to share with the audience? Because you told me a couple the other day, just in passing.
Yeah, it's hard, It's like I said, they're all become family after a while. Like I said, we see them so often. And there's a negative to that also, because when something happens to them, and it might not be from the kidney machine, maybe the disease that got them there.
Right.
If they went there because of diabetes or strokes or heart disease, they could still have problems with that, even on dialysis. It doesn't cure those other problems.
Right.
So all these people, some of them have been very blessed. I have one young lady that she was started as a pediatric patient at Philadelphia. At 18, was transferred to me when she got older. She's had, in all this period of time, a couple transplants and other diseases, had lupus at that point. She's now 54 years old, still has lost a kidney, is still my dialysis patient. Again, she's been on and off again. And this girl, if you had seen this young lady, she was working, she was married, she looked like anybody else on the street, you wouldn't even know it, from 18 to 54, and how many years is given, because you can't live without your machine. And it's just amazing. In fact, she always thinks I'm her father. So watch out, she wants some of my inheritance. She keeps kidding about that. She wants my car.
Tell her to stand in line.
Oh, no, yeah, she wants my car and everything. But jokingly, she's really, and saying they were transplanted. I had some 18-year-old kids that were transplanted that are still not on dialysis, but are followed by me for transplant. Young kids at 18 are now 40, 50 years old.
Right.
Don't go to the transplant center. Haven't been there in 30 years. They got it at Penn or different places. Come to us for follow-up. We take care of their transplant medications and treatment. And fortunately, they got good kidneys. But we've had lots of these, and some emergencies that I remember that stand out that I'll never forget. Just one quick one.
Yeah.
One of our patients came to the emergency room, and myself and this is in the 70s, and a heart doctor myself went to this patient, and he was one of our chronic kidney disease patients. And we couldn't do anything with him. And he lost his heart rate, and it looked like we couldn't get him back. The cardiologist left, went back to the room, and I said, well, give him some calcium. Just try it, because he may have high potassium. And that's something that's stops people's heart, yet it's treatable. The nurse gave him in the emergency room 2 treatments of calcium. His heart rate came back, and I asked him for a peritoneal catheter and the bottle. And right in the emergency room, I put a tube in his belly because we did it by hand. We didn't go to the operating room. We just put a catheter right into the belly, got the fluid, ran it in, ran it out, ran it in, ran it out. This guy survived. And 30 years later, he got a transplant, still alive, still came to my associate for his treatments. And it was amazing every time I saw this guy because the cardiologist just left already. He was pronounced dead. And we just took a chance. And this guy 30 years later, because of that kind of situation. But the things we did in the 70s, you wouldn't believe. I mean, we put catheters at the bedside into the belly to do peritoneal dialysis and did treatments right there. And the dialysis, the shunt that I told you we used to take blood from the patient and put back in the patient was done by nephrologists. We did the surgery. It wasn't until they got into these fancy vascular fistulas, what they needed, that we did all these things. And so in the 70s, we were doing everything, nephrologists. And when I came to Trenton, there's not one single nephrologist other than my partner, 4 of us. And I took over not only that, the 4 hospitals in Trenton. I actually went to St. Mary's and also went to Princeton at the same time in Princeton. So I went to 6 different hospitals with 2 nephrologists for the whole place, 6 different every night. In the emergency rooms, we had no residents. The emergency rooms were being handled by doctors that weren't trained in emergency room. And they were calling us every night. They didn't know how to take care of a kidney patient. When they saw a kidney patient, they'd call us. So every night we were in the emergency room. And to my dismay, it took away from my time with you and your brother.
You were there.
Your mother.
Give me a break.
And my animals. But we spent so much time at the hospitals and yet still wanted to see you play basketball and raise a family.
I don't remember that being a
lot of specialists, unfortunately lose family care. And to be a doctor, we could talk about that, but to be a doctor,
we are going to talk about it. Which brings me to my next question, which is after 5 decades of medicine, very few people really are even talking about the changes in medicine have been remarkable. In the beginning, you're saying you were in the trenches, you were doing everything because they didn't have subspecialties, they didn't have surgical interventions that you could call, and you were doing it. In fact, back in the day, I recall you telling me we didn't have pagers, right? You didn't have pagers. So where did they find you, Dad? Where did they find you and your friends in residency and in medical school?
We had a pager.
Oh, you did? Because I remember they used to call the local pubs to find you guys. No? I thought you told me that.
That too, that also. But the pager I have then, I still have now.
Oh, okay, gotcha. You still have the same phone, that is for sure.
It wasn't the cell phones. These were pagers. You can ring and then you have to call back the operator. It would just beep her and you call and you say you got an emergency at certain place.
Oh, I had a different story in my head. They called each of the local pubs. And anyway, which is probably not.
That. I won't admit to it.
You won't admit to it. Okay. But what's your opinion on the changing of medicine? So let me just let you speak. Like, really, all these years, what's your thoughts?
Twofold. One is my specialty, and 2 is general medicine in general, what's happening to medicine. From my specialty standpoint, people are not going into nephrology. They don't want to take my specialty. They think it's too hard. They don't think it's too many hours. People have changed their lifestyle. They want to be home with their families. So nephrology has not been a good specialty at the present time. They can't fill the spots. And it's very difficult. It's sad. And as the older people like myself leave the field, they're not being replaced. In general, medicine's having problems. As you well know, the hospitals have taken over most of the practices. They own them, they buy them, and everybody works for the hospitals. I talked to residents today. Half of them, or more than that, want to be hospitalists. They don't want to open a practice. They want to work for the hospital 3 days a week, hospitalists.
No overhead. They don't want any overhead. Right.
That's right. They can't get nurses, no overhead, too costly the hours. So most of them want to be working full-time at hospitals. When we were doctors, at least my attitude was, I wanted to be independent. I didn't want to be owned by anybody. I had my own ego. That's why I wanted to do medicine. I'd be my own boss. Today, you can't be your own boss. The hospital owns everything. And it's a shame because we can use 100,000 internists.
Right.
So what's being replaced? We're getting a lot more nurse practitioners that are taking a lot of the spots. Nurses, in general, we can't get nurses to go to the hospital or my kidney units. We're so short of nurses for kidney treatments, we can't get them. Yet the nursing schools are packed. People are going into nursing schools, but They don't want to do bedside. They want to work in an office. They want to be nurse practitioners. They want to do other things, but they don't want to go to the hospitals at bedsides anymore.
Right.
So it's a very difficult situation, and it's hard to get doctors. When is the time allotment that's needed, and the economics, the costs, to become a doctor, and you can't be independent anymore. The big guys are beating up the little guys. The small hospitals have sold their cells to the big, and very few independent practices.
Yeah,
in my hospital alone, we're only about one or two specialties that are not owned by the hospital. We're one of them. But we don't want to be full-time hospital people.
Do you feel like you've mourned the loss of autonomy? Because, these kids coming out of med school really don't know the difference. And so they're sort of not missing anything because they're walking into sort of 9-to-5 jobs or salaried or, you've seen the whole gamut, the whole evolution of medicine from your time till now. I feel like there's a sadness involved there. I don't know. Do you feel that way, or are you kind of ready to get out, or what's your thoughts?
I'm surprised because I ask them, and they were going into specialties, and very few are. They're not going to, like I said, they want to be hospitalists. Mm-hmm. They want to have a full day and go home and no calls. And economically, they're getting paid very well. The problem with it is it's going to be saturated eventually. Everybody can't become hospitalists.
Right.
And you can't just turn everything over to nurse practitioners alone, although they're out there doing a good job. And replacing a lot of physicians, offices, you'll find that you'll still see a nurse practitioner. You may never see the doctor, but he's there for backup. But you might go there a year and never see that doctor. 2 years, the nurse practitioner is doing all the treatment or follow-up on situations. Do I find it sad? Well, I love medicine, or I wouldn't be doing this. Some people retire and go to the golf course. I don't like golf. I like to watch it, but I don't like to play it. And I feel I am in retirement, but I'm still practicing. So I enjoy what I do. But that's what other people, it's sad. In nephrology, one sadness about nephrology is when I say to you, we get to know our patients more than we know our family and see them for 20, 30 years. Yeah. When something happens to that patient, you got to put it aside. We see hundreds, thousands of patients, unfortunately, in my 50 years, that die, not because of the dialysis so much, but a disease that got them there.
Right.
And it's a very sad situation. And I got patients one patient is 92 years old. He comes to my unit. He's 92 years old, comes in with his walker. He's doing fine. He's with his family, and a choice he had to make that he want dialysis. Some people at 80 say, I've had it. Not true anymore. We're seeing a lot of older people in 70s and 80s, although we're trying to treat them medically, and the government actually wants you to treat them medically because it's very costly to treat dialysis because they're paying for it. Right. Medicare spends billions of dollars controlling these people, but they're doing well. So age no longer makes the role, but they get so close that I know nephrologists that actually left nephrology. They become a medical doctor because they couldn't stand anymore losing patients on a regular basis, because that's what you happen.
Similar to oncology. You're basic.
Oncology is the same way. And you have to have a tight background, be very standoffish at times, because every time I lose a patient of mine, I'll call that family and discuss it because I know them. So I always make that phone call. But the bottom line is it gets to be hard sometimes when you treat people for years and years and years. Right. Like family. My field, I love my field, but that's what I was trained in.
Do you have any regrets about going into medicine? Because you started off, you hustled, Dad. You hustled to get into med school. You gave blood once a month to pay for it. You worked 4 jobs. I'm touting it because you won't. But, back in the day, you didn't grow up rich, and, you really did.
No, I never resented that at all. I carried 2 jobs. You said, every chance I had, my parents had no money. I put myself, but it was cheaper then. It's not the way it is now. These $70 million, $70,000.
That may change if they pay for med school.
I worked every summer. I worked every Christmas. Carried mail bags at Christmas and carried 2 jobs in the summer. Never took a summer off. It never bothered me. Never thought bad about it. And when I went to Hahnemann, where I did my training, the 2 specialties there were either the heart or the kidney. Because when you train what you see. Right. And the specialties that were there. And I would have gone to Boston in cardiology, except that it was full. Everybody was going into cardiology at that time. That was the field to go into economically, and it had the color. Everybody wanted to be a heart specialist. And the other field at Hahnemann was nephrology, which was not so clear to some people. And that's why I ended up in nephrology. I chose one of the 2 things that were available to me that I saw on a regular basis.
And you loved your mentors.
I loved it every bit.
You loved your mentors for nephrology there too, didn't you?
The 4 fellows that I dealt with were like brothers.
Yeah.
The mentors went to dinners with them. I mean, that's how friendly we were. I mean, I went with my mentor that I did. I know for years. In fact, that mentor, surprisingly enough, it was his first year he became the mentor, and I was in his training, his fellowship, also trained your brother.
Yeah.
The same doctor trained me, trained your brother to be a kidney doctor as well.
Yeah.
It's a strange phenomenon.
Yeah, and so to clarify, Hahnemann is no longer. It was a Philadelphia hospital, but along with the other hospitals that were there, you know, Philadelphia General, right?
That's gone.
Those were the old Philadelphia hospitals that you just were gritty and you got in there and you learned medicine.
We rotated around to Philadelphia General, did a lot of training there. I even worked in the TB hospital. It was in Philadelphia, Girard Avenue, and still there. Worked there at nighttime. Seeing patients, admitting them. We went to Wilkesboro. We went to different places for training. And we didn't always stay at Hahnemann.
Right.
Loved Hahnemann, though. I thought Hahnemann was a great place. Did 8 years there. All my training at Hahnemann. Yeah. And I was very sad to see when they became Drexel, took over to medical school. Yeah,
well, it became Tenet, then Drexel. I mean, even when I was at medical school
Tenet took over the hospital. Yeah. Drexel took over to medical school.
Yeah.
And I lost a relationship between that. Because even at our 50th anniversary, you had to go back. It had a 50th anniversary. Drexel gave out all these certificates and all that stuff. Only 10 people showed up.
Yeah, I mean, it's hard because, you know, I went to Hahnemann. It was MCP Hahnemann. My husband went to Hahnemann. My brother went to Hahnemann. You went to Hahnemann. We have so much Hahnemann love, and then Hahnemann no longer exists. Kind of like St. Vincent's and some of these other beautiful, Beth Israel. Like, a lot of them are going by the wayside or getting
larger hospital. They're going out of money. They can't afford it. And the larger hospitals are taking over all the small
they're absorbing them. Yeah. So then the name and sort of your sense of history and your being gets a little disheveled there because it's like you don't really remember you don't have a history, a place, to drive by anymore. But anyway, so, I love the fact that you have some incredible patient relationships. I remember when we were kids, we'd go in and we'd meet, the seeing eye dogs, and I would play with them while the people were in dialysis. And, it was just a remarkable time. And I also wanted to share, you used to get some pretty incredible Christmas gifts, Hanukkah, Christmas, whatever you want to call it, Christmas gifts. Do you remember the butcher that you took care of and what showed up at our door?
No, that's the thing with dialysis. Like I said, they're all family. Everybody's family. And they seem to know when you're having a birthday. They know when you're none of that. Even today, when I walk into a room, or maybe because I'm older, the patients I see today in my office, I walk in and say, "How you doing?" Guess what they say? "How are you doing?" And it's really strange. After all because I've been taking some of these people 30, 40 years. I got patients here that 40-year patients. But they actually asked me, because I got my own medical problems like everybody else, I'm not young anymore. And they actually asked me how I'm doing. And they asked me, the next question is, are you going to retire?
Right.
Because I've known them so long, and I have to make them feel like, absolutely, I don't want to retire. I may be forced to, but it's not my choice.
Right.
But it's amazing how patients have get close to you.
Yeah.
Those patients, we used to have Christmas parties at the dialysis unit every year. And that's when we used to bring you and your brother. And those patients were just so nice.
Yeah.
You wouldn't know they were all sick. You didn't know who was sick, who was the nurses, because dialysis people don't walk around limping and showing their arm or showing their fistulas. You can't tell a dialysis patient on the street. And they live decent lives. And unfortunately, there's no choice. Right. And hopefully, the main thing is to get a transplant. Right. And that's a whole different story, that if you got a cadaver that somebody dies, it's fine. If you got a relative. But the wait now for dialysis is 3 to 5 years.
Wow.
3 to 5 years for a patient on dialysis, unless they get a donor.
To get a kidney
transplant.
Yeah.
So they sign up. They try to get it, they get tested and everything, but they can wait 3 to 5 years for somebody who may expire and donate their kidneys.
Huh.
It's interesting in this country, we don't always have a lot of donors. In France, way back then, the French had the opposite. You had to have a card to say you don't want to donate, as opposed to we have a card that says you do.
Really?
It was a French man who was so famous in nephrology and political control. He had that passed, that if you don't carry a card to say, I don't want to be a donor, and something happened to you, you were a donor.
So you had to actively...
I'm not talking about just kidneys. I'm talking about eyes. I'm talking about everything.
Yeah, you had to opt out.
You got to be card carrier here to say you want to be a donor.
Are you an organ donor?
Not at this age.
Not at
Nobody
this
wants
age,
my organs.
But philosophically, you are. I'm an organ donor. I'm just curious
At this point, it's beyond because multiple reasons. I'm just beyond that age. What might be.
Right.
But would I be? Yes.
Yeah. Okay,
but it's not just kidneys. It's everything. It's,
sure.
People nowadays, one person,
Corneas,
a young person,
and it's
absolutely,
amazing.
They can help lungs and heart and things like that today. But it was interesting how the French handled it.
Yeah, well, French have a different perspective. I read a book about how the French handle mastectomy and breast cancer, and they do everything you can possibly do. I remember a journalist traveled to different countries with the concept that she had breast cancer and what would happen. And she was really writing about the different cultural effects that people have in different cultural medical, where, there was just a different philosophy, in terms of how much to save the breasts versus, other countries. So I found that unique. I don't know her name. I wish I could. It was a great book. But the reason I mentioned your patients loving you so much is because I see it from a different perspective. When we were little kids and you had, I believe, a butcher as a patient, and lo and behold, one day this huge truck shows up and starts delivering frozen meat to us. And we had to get another freezer. Do you remember that? I remember meat coming through the door like nonstop, and it was one of your patients.
Some of these things go past me, like I take for granted because patients are just nice. They'll bring things in. Patients will do things like that.
If they like you, Dad. If they like you.
After 20, 30 years, they have no choice. They get to like you because they have a different personality when you start out. And listen, in Trenton, it's not the most wealthiest environment you have in Trenton. These are the nicest people, and it's an environment which don't have the social economic that Princeton does.
Right.
And I go to Princeton. I have patients in Princeton unit and all. But if you ever worked in Trenton for 50 years, it's a lower income area. And these patients have a lot more problems medically, like I said, for diabetes and all. Economically, they can't afford the nice foods that we like to have. And the things we like to train them to go home and do this and do that. That's why McDonald's does so well in Trenton, because they can sell a $5 meal to a person who only makes 30, 40,000 and things like that. So we see a lot of this. And what I can sell to older people, and the patients should be aware of it also, and these doctors when they come out, early prevention, early evaluation, prevention, and that goes back to medical school.
Right.
That's the one big thing we still don't see, and we need to see that the doctors coming out have to be taught prevention.
Thanks,
when
Dad.
they come out of medical school. Unfortunately, the other side of it is that if you have a 20-minute visit, it's hard to treat, especially like they're coming to me because they're sick. How much time can I spend to treat that sickness and then go? Prevention is hard. There's not a lot of time elements involved, but they got to start medical school prevention to learn that all and teach doctors how to talk about it in their offices. And for us, early referral, because we can stop things and control things. They don't have to be on dialysis. Not everybody goes to dialysis. And to understand for us, dialysis is not the end of the world. These people survive. They have families. They work. It depends on the other diseases that might cause it, like diabetes and hypertension, strokes. But the dialysis machine does not tie people down and end their lives, which some people fear when they hear that word. They come to my office as a referral. The first thing they're worried about is that word dialysis. And as soon as they walk in the door, I tell them, you're not here for that.
Yeah.
You're here for evaluation, diagnosis, and prevention.
You're giving them perspective because you've been doing this so long, to give them an idea, to take them off the ledge that they may never have to stay on dialysis if they keep going and doing their preventive measures.
They're being referred and they think that's the word they hear from the primary care doctor. And you got to stop them as soon as they walk in the door. This is not what you're here for. You're not even in that world. And let me help you, but to teach the doctors coming out, that word prevention is so important, and it's still somewhat difficult.
So give me 5 things that you tell people, or you would tell medical students. Give me 5 things that would help save the kidney from getting damaged or becoming ill.
Well, it's the diseases. 2 I just mentioned is early referral. When your doctor goes there, he gets a routine blood study, which has the creatinine, tells you about the kidney. He gets that urine protein, get him to a nephrologist or whatever specialty they need. But don't, try to carry it too much. Let us be involved in their care. As far as that goes. As far as patients go, obviously we like to see weight loss. We like to see good nutrition. We like to have people trained on what is good nutrition and exercise on a regular basis. The most problem thing is diabetes. How do you control diabetes? How do you control hypertension, high blood pressure? For us, they got to go to a doctor, take their medicine, but it's an economic thing as well. And the other diseases that may occur in your field, early referrals from your field and the things that you do, and the drugs are out there to help. We don't like to talk about drugs too much.
Right.
The pharmaceutical companies have taken over the world and sell drugs that may not be necessary. We know that.
You've come full circle, Dad, because I don't think you realize how integrative you are, even though you've never formally been trained in integrative medicine. But everything you just talked about, less medicines, more prevention, better nutrition, more exercise, literally, that's integrative medicine.
I know, but it's time.
Yeah.
You could do it because that's your specialty.
Right.
When they come to me, the first thing I'm doing is ruling out the etiology and cause of the problem they have. Why is the creatinine there? Is it lupus? Is it diabetes? What's causing the kidney? I might have to do a kidney needle into the kidney, a biopsy, which is the gold standard. That'll tell us the tissue looks like. Controlling the blood pressure, explaining to them what's going on at that point. But that takes time. And you can only see so many patients. We're not Marcus Welby, where if you can spend a whole day with a patient, I can train them to do anything.
Right.
But if I only have 20 minutes, the next patient, or a half hour for an older patient to come back and forth, we don't have always the time. And we need the specialties like yourself, and to do nothing more than preventive medicine, or have a separate day for preventive medicine. Right. And that's the most important. But controlling diabetes, controlling high blood pressure, controlling the cardiac status, good diet, situation, making sure exercise, all the things we tell them. And yet people, unfortunately, can't do all that because they're carrying 2 jobs.
Right.
And Trenton particularly. And it's an environmental thing. I I told you, Princeton, you can say, go to this good food place and get all the good food and all that kind of stuff.
It's a socioeconomic issue.
Oh, absolutely. They have to budget themselves, and unfortunately, that takes in the cheaper foods.
But I will say, good food, and we've talked about this, good food is actually more accessible than it ever has been because frozen organics or frozen foods are really filled with nutrition. They're cheaper. It's just, access to get them and to unfreeze them and to, defrost them and to cook them. I mean, that's just life in general. There are busy people that have money too that can't do that.
But the doctors don't know this.
Yeah.
Your general practitioners, your internists, specialists, we don't talk about good foods and frozen foods. We send them to you if they can get to you. But we have to have some people that just do that or come back separately for that one reason. But we're talking about, hey, your blood pressure, I got to give you pills for that. Your diabetes is well out of control. I got to give you something for that. You're getting heartburn, so you're taking this medicine every night for heartburn, which can hurt the kidneys, but you have heartburn, and the GI doctor treats that person for that heartburn. They come to me and I see that drug and I call the guy and say, does he really need it? They had one attack, they're taking it 10 years later, is taking that same pill, which hurts the kidney.
Like proton pump inhibitors, for example. Taking it off? Right? Proton pump inhibitors have a risk of raising creatinine. People don't really realize that.
Well,
now, you may need it. You may need it, but there's also...
specialists that understand that preventive situation.
And alternative choices to medicine.
Medical school.
Right. Oh, that doesn't happen in med school. And it will not happen in med school because I reach out to them now and they don't want prevention. But your point is that medicines cause problems potentially. If they're needed, you want to use them for the least amount of time at the lowest dose. And also understand there's consequences, even organ consequences. It's not
just medicine. It's foods and there's other things there. And I agree that medicines have saved a lot of people, especially the diabetics. The high blood pressure pills, the renin, aldosterone, system. The new drugs that they have out there, the ACEs and the ARBs, particularly a group of medicines we talk about, has done so much for people in diabetes to control diabetics over the years from the 70s that I've seen. And I've seen that transition up to the present time. It's a major change, but still diabetes. And it takes a lot of education, a lot of economics. We're going through that now. And one other thing that happened is that COVID situation, which we didn't mention, but it had a tremendous effect on dialysis patients.
Yeah. And what
transplantation patients, the vaccines didn't work on them. So when he gave vaccines to transplant patients, 2, 3 doses, still low levels.
Because they couldn't mount a response, right? They couldn't mount an antibody response.
Of course, they're taking medicine to protect the kidney, which affected this.
The immune suppressants.
And on dialysis, the number of dialysis patients that expired during COVID was tremendously excessive. A lot of dialysis patients lost their lives during COVID because they had the illnesses
Right, they're
despite
immune
the vaccines,
compromised with comorbidities.
oh, and they were sick, with very sick people. I mean, you talk about the older people, but they were very sick. And a lot of our own patients, my people that I treat or my partners treat, or generally, statistically, lost their lives during the COVID situation. So COVID had a very big negative effect on dialysis patients. And transplant, at least you had to really be on top of it.
Right.
And had to give extra doses of the vaccine, not just 2, maybe a third or even a fourth, just to protect them.
I'll tell you, a lot covered here, Dad. I got to be honest. I think I've learned a lot. I hope the audience has learned a lot. What's your favorite, if you had to pick one thing about medicine, if you really just want to touch one thing, what's your favorite thing about medicine? If someone were to ask you, what's your favorite thing?
I know that's a tough one. I mean, it's, to me, just when they come to visit me in my office and I get new laboratory work, the best thing I can see is nothing changed or it got better. And every time a new person comes to our office or a return visit, we have new laboratory because we watch these lab studies. And the nicest thing I see when I look at it says straight line or even improved. So that's fine. But watching people grow up and know that they might have not been here if it wasn't for some procedures that are now available that weren't available in the 70s.
Right.
In the 70s, just imagine, it took 12 hours. 100 people came for dialysis. One that needed dialysis, 10 got it. The other 90 didn't have treatment. That's in the 70s. And went for a committee that said, sorry, even though you have a wife and kids, that we can't do anything for you. How sad that was. We don't do that today. I don't care. We're short of nurses. Doctors don't want to go into nephrology. We'll work 24/7, but nobody gets turned down for dialysis. Nobody. Even in the 90s, if they really need it and all, we'll talk about it situation. But the ability to be able to treat people and not say, I have no treatment for you, is very sad. I know the oncologists go through the same process.
Right.
They see things they want to, but for us, I don't care what time of the day it is, what it is, we'll always find a way to try to treat somebody and not neglect them. And that's the best part of dialysis, is to see people get well and treat.
Well, I'll tell you something.
And I got young people that work with me that do that. I got good staffing. That's why I did it so much. My office staffing, my partners, and everybody else out there that are really, a part of a team. And nobody's tougher than dialysis nurses. I got to give them credit. They do work that are unchallenged in any other field, because they have to watch patients for 8 hours, check their vital signs every 20 minutes, half hour, keep an eye on them, see sick people, stick needles in them, and we can't get dialysis. It's too hard.
Yeah.
But those girls work so hard as ICU nurse and all stuff. But I have a lot of attention towards the supportive people. The nursing people.
Well, I think we got that answer, because I think you love medicine because of all the human contact and the human emotion and all those things. Last week I went to see you just to chat in the waiting room of the dialysis because it was just on my way. And you're saying, bye, John, go check that pulmonary situation. And Mrs. Jones, it's hot out. Make sure you hydrate. I mean, you just thrive in this environment. And I think it's just a testament to such a beautiful career that you've had, and you keep going to work. I mean, you still are practicing, and all the liquor bottles we got growing up that made it into the closet, which, even though you're not a drinker, I won't tell you about high school parties, but the idea that people just really love and respect you. And I think, your reputation.
I don't even know that sometimes, because sometimes they get.
You're going to poo-poo it. Forget it. I didn't want to say it because I know you're going to poo-poo it.
Because dialysis patients are sick people. And sometimes they get very aggravated and anxious and get mad to my nurses. And I'll tell them, just say if you were in that chair, how you would feel 3 times a week, 4-hour treatment, the rest of your life. How you feel, just back off a little bit. So I always have to tell my nurses, if they yell at you once in a while, patients and all, and act outright, not to hit you and not to curse you, but understand that. And those nurses are great. I got to give credit for the nursing staffing and how they do these things.
Right.
And
empathy, you're describing your empathy. You've done this long time and you're still not hardened to it, which I think is another thing. A lot of doctors and a lot of people in any field, but a lot of people in medicine, they become hardened to just the sadness, the sickness, the complaints, the chronic illness.
It's there.
But you still have the empathy, Dad. That's what I'm saying. And by the way, the other thing is I went to visit you and you were still parking, not in the handicap spots, even though you have knee arthritis, but you were still 5 spots away. And I said, Dad, why are you not? And it just shows who you are. You let patients come first and you wanted to leave those open. So I really kind of had to mention that because it's just a testament to who you are. So I'm going to close now. I want to just say that it's been such an honor to be even, I guess, your daughter of a doctor who takes so much care with medicine. I mean, you have 2 children that went into medicine. And we had early exposure to this kind of care and empathy. And I just think it's just a remarkable thing. And so I'm so glad that you took the time, even though we had to arrange it in many different ways with the computer and all that. But I'm so thrilled that you took the time to chat with me, because this is something that I'll be thrilled to have as part of my library repertoire to share with others. So anyway,
I never forced you to go into medicine. Either one of you two.
No.
It had to be on your own to see it, but it was never my idea that you had to be doctors.
I know that.
And you know how I feel. I'm proud of both of you for being that way. But I just felt that hopefully it would rub off, maybe, but not pushing. And,
I think you can't be pushed into medicine. It's too much work. But it's just too much work.
One time I thought it was today it is. Today it's a different world. The medicine's not as generous and wanting as it used to be. And I wish it was, because we need doctors. Primary care doctor just needed.
Right.
And they just don't, for one reason or another, not doing it. Yeah. But we need 100,000 primary care doctors. Yeah. That's medicine today.
Yeah, that's a whole nother story for another time. Okay. But I'll tell you, what you contributed to thousands of residents that you've trained and CME programs that you put together. And, it's just remarkable. And yet, at the end of the day, you've maintained all of your, your empathy, which I think is just really remarkable. And I really hope that physicians, even in training or wannabe people in healthcare, will.
And I'll give you one more shout out for you. Their family has to be supportive.
Yeah.
Doctors, especially nephrologists, you have to have a wife and children that are willing to give up time.
Right.
For you to do that, because nephrologists particularly were 24/7. They weren't like 9 to 5. And they couldn't always be at basketball games and all. And they couldn't be the wife got sick. They had to be things. So you had a very supportive family. A lot of guys lost their families in medicine. But to have a supportive wife and children.
Shout out to Mom, who's going to watch this.
And a good dog. Yeah. Always have a good dog available. A good
Maybe
pet.
Especially good
I love
couple of pets.
Always have a pet to come home to, because that's who's waiting for you at the door when you come home at 11 o'clock at night all the time. So I just wanted to add that little.
Or anything else you catch.
Or a cat or anything. But somebody.
Anything you catch.
It's not just the family waiting for you at that door. And
you're an animal lover.
I just had to add in.
It's not so far off from what you do anyway. Right. You're an animal lover. You're a human lover. Animals. Anyway, Dad, love you so much. Okay. And thank you so much for spending this time. And
my pleasure.
I can't wait to put it out there at some point. And, you're the best. So thank you for everything you've done in my career as well, in my life. So.
And I'm very proud of you. Thank you very much. And your brother. And I told you. Okay.
Love you, Dad.
All right. Signing off.